Hey everyone, this is Desma Rozovics from the Illinois Academy of Family Physicians, and I have the honor of introducing our next speaker. Dr. Fischer Herald will be speaking on multi-drug resistant organisms and novel antimicrobials. Dr. Fischer is a first-year infectious disease pharmacy fellow at the University of Illinois at Chicago College of Pharmacy. He graduated from the University of Iowa, go Hawks, College of Pharmacy, and completed his PGY1 pharmacy residency at Northwestern Memorial Hospital in Chicago. He then went on to complete his PGY2 in infectious diseases at the University of Illinois at Chicago, and his practice interests include implementation of stewardship services in community and outpatient settings, while completing clinical research focused on therapeutic modalities in COVID-19 and working with the ACTIV-1 and ACTIV-2 clinical trials. After fellowship, Fischer will be working at Rush University Medical Center as an antimicrobial stewardship infectious diseases pharmacist. And outside of work, Fischer enjoys playing soccer and, of course, watching those Iowa Hawkeye sports. And I just learned that Fischer and his wife have they have a new little pug dog named Lola. So from here, I'm going to send it on off to this is Fischer Herald.
Thank you so much for that wonderful introduction, and thank you for everybody that is here today. Apologies on the technical difficulties without the camera, but we'll move forward. So I have nothing to disclose in relationship to this presentation. Overall, I'd like to review the epidemiology of multi-drug resistant organisms and review specific MDROs that may be more applicable to clinical practice. And then we'll review some of the antimicrobials that work towards targeting these specific organisms. So this is from the CDC, and it identifies 6 of the most 18 alarming resistant threats, and they tag a $ associated to it, which I think is very interesting. And as you can see here, these threats consist of organisms that we may be familiar with from the hospital setting. And throughout this presentation, we'll take a deeper dive into each one of these organisms or class of organisms. This is the full list, just for completeness sake, of the antibiotic resistance threats that are identified by the CDC. As I mentioned, we'll only be going through those ones that are associated with more common incidents or associated with higher costs with healthcare systems. The first organisms that we'll be looking at are vancomycin-resistant enterococci. Enterococci, they're normally found they can cause urinary tract infections, potentially bacteremia, intra-abdominal infections, endocarditis, a whole host of infectious syndromes. But about 30% of all healthcare-associated infections are resistant to vancomycin when being infected with an enterococcal species. Enterococcus faecalis causes the majority of enterococcal infections, where Enterococcus faecium causes a substantial proportion of enterococcal infections that are actually resistant to vancomycin. But nearly all of these infections happen in patients that have risk factors, such as staying in long-term care facilities, undergoing...
Hi, Fischer.
Oh, hi.
I'm so sorry to interrupt, but we're getting a couple of comments that people can't really hear you. Is there any way you could speak up a little bit louder?
Yep, I can do that. Is this a little better?
Yes, I think so.
Okay.
Thank you.
Sorry about that. Again, technical difficulties. So again, this is classified by the CDC as one of those serious threat organisms. So as we can see, cases over time, thankfully from 2012 to 2017, have actually been going down. And we can see the hospital versus community onset infections. And there were significant decreases in both of these types of infections, around 30,000 fewer cases in comparison from 2017 to 2012. And really, what we can attribute some of these decreases in incidence of infections to are appropriate infection control measures being in place, as well as appropriate antibiotic use to decrease the overall incidence of VRE infections. So the characteristics of vancomycin-resistant enterococcus, there are various types of these VREs that have been characterized both on phenotypic and genotypic bases. But summarized here, we can see VAN A, VAN B, VAN C, D, and E, whereas VAN A and VAN B are the most common variables that will be present in a vancomycin-resistant enterococcus, and they typically are transferable, which is unfortunate, as that means from one species to the next, this resistance gene can be transferred from one to another. So from a microbiology standpoint, they're a significant component, again, of our normal colonic flora, but they're present in the oropharyngeal as well as vaginal secretions, and they're found in the environment, in soil, water, and food. They're facultative, anaerobe, gram-positive bacteria. They do produce biofilms, and they have species-specific antimicrobial resistances, such as a high beta-lactam resistance in Enterococcus faecium, but uncommon in faecalis. And as I mentioned previously, vancomycin resistance is more commonly found in that Enterococcus faecium species as opposed to Enterococcus faecalis. From a clinical assessment standpoint, when someone is infected with the vancomycin-resistant Enterococcus, catheter removal is oftentimes one of the best options for our patients, even more so than potentially giving antibiotics, is if that's the nidus of infection. Source control is key in these infections, as well as surgical drainage, IND, and debridement. And there could be multiple sites of infection, as I mentioned. They don't pick one. They can cause a whole host of infectious syndromes. For our treatment options to treat VRE, they're listed here. These drugs and doses are oftentimes requested infectious disease consultation and required for the prescription of those in the inpatient setting. Things like linezolid being bacteriostatic, sometimes resistant may emerge during therapy in addition to daptomycin if we're not dosing it correctly. It is bactericidal though, and it is but again, resistance has emerged during treatment of VRE infections with daptomycin, and a few other not as commonly used antibiotics listed as well. Moving on from VRE, we have methicillin-resistant Staphylococcus aureus, or MRSA. There are many treatment options available, but there are concerns of increasing resistance over time with MRSA, as well as certain patients being at a much higher risk of acquiring these infections than others. And as listed here, you can see that certain patient populations who are more likely to be infected with MRSA, as well as how many hospitalizations occur. And it's now very common that we experience methicillin resistance in North America, but interesting, in the European countries as well as Northern European countries, this is not as common and not as much of an issue. So again, pulling data from the CDC, looking at MRSA cases over time, following a similar trend to that of the vancomycin-resistant Enterococcus, we have been seeing a decrease in incidence of MRSA infections. One thing to note about the data listed here is that these cases don't represent the potential many skin and soft tissue infections that happen but are not cultured and diagnosed. So that's something to know about this data, but it is still good to see that overall cases are decreasing. So as far as resistance mechanisms, there are primarily three different ways that Staph aureus can develop resistance. So we can have an alteration of the target, so the D-allyl-D-alanine switches to D-lactate or D-serine. This results in a loss of a hydrogen bond, decreased vancomycin binding affinity. Things like this that exhibit this type of resistance would be like a VRSA or vancomycin-resistant Staph aureus. Increased cell wall thickness, this is actually not a change from the D-allyl-D-alanine, but just an excess production of it. Vancomycin becomes trapped by the excess and cannot reach its target, or other antibiotics for that matter. And then finally, we have just overall extensive exposure to vancomycin itself can actually result in MRSA developing resistance to vancomycin. From a microbiologic standpoint, it's an aerobic gram-positive cocci, usually seen in clusters, oftentimes noted on a gram stain in the clinical setting. Methicillin resistance is conferred by the MEK-A gene, and oftentimes this is from the penicillin binding protein 2A, and thus leads to the resistance of our common beta-lactams that we may use to treat MSSA or methicillin-susceptible Staph aureus. There are community-acquired MRSA isolates, and those often have a more broad susceptibility profile with things like tetracycline, trimethoprim sulfamethoxazole, or Bactrim, as well as clindamycin. Clindamycin can be a little bit tricky in this setting due to the fact that susceptibilities vary geographically, so definitely relying on local antibiograms can be key in that setting, as well as if the isolate is erythromycin resistant, we must confirm clindamycin susceptibility with a microbiologic test called the D test. And as I mentioned briefly earlier with the different mechanisms of resistance that can develop even with MRSA, we can experience a vancomycin intermediate resistant Staph aureus as well as a completely resistant Staph aureus. Thankfully, at least in the Chicagoland area, these are fairly rare and not very common. And again, it's mostly seen in patients that have been either highly exposed to vancomycin therapy for longer durations or have a high healthcare association. From a clinical assessment standpoint in a patient that is diagnosed with an MRSA infection, again, it has been traditionally associated with the healthcare system, but community-acquired MRSA is now a significant pathogen, and we're seeing more and more community cases. Similar to VRE, there's a whole host of infections that can occur, and every organ has the potential to be involved, especially with bacteremia. Of note here, we do, like I mentioned, we do still have a plethora of options to treat MRSA. Questions start to arise when we have persistent MRSA infections or bloodstream infections. There has been some research that has looked at this, specifically the CAMERA-2 study. This was a study that is the largest MRSA bacteremia randomized controlled trial to date. They looked at investigating a 90-day complication-free survival in patients. These patients were either treated with monotherapy if their MRSA bloodstream infection with vancomycin or daptomycin, and they compared that to agents with either agent plus 7 days of an IV beta-lactam, such as flucloxacillin, cloxacillin, or cefazolin. In theory, the theory behind this paper is that the addition of the beta-lactam increases the net cell membrane surface, enhancing the effects of daptomycin particularly, and actually the host defense peptides enabled to target the Staph aureus. Unfortunately, the trial was halted early due to an excess of renal injury in the combination therapy arm. Primarily, over 99% of the patients prior to the study stopping were actually enrolled in the vancomycin arm as opposed to the daptomycin arm, but there was no significant difference in endpoint from their 90-day complication-free survival. Hopefully in the future we'll be able to include additional research into the optimal duration of this combination therapy, preferred beta-lactam agent, as they were picking between 3, as well as considerations of the additional toxicity profile when we're adding new agents. Moving out of the gram-positive realm of the VRE and the MRSA now and hopping into the gram-negative world, just a brief overview of the Amber class summary, which highlights the different classes, whether A, B, C, or D, and the beta-lactamases that are associated with each class. These are periplasmic enzymes that hydrolyze the beta-lactam antibiotics, and this prevents the drug from reaching the desired penicillin-binding protein target. And again, they're classified into these 4 distinct classes based on structure. Classes A, C, and D use serine as a nucleophile to help hydrolyze that beta-lactam bond, and then class B uses zinc, and those is why they're known as the metallo-beta-lactamases. You can see here, based on the activity, example enzymes that may be identified in the clinical setting, as well as common bacteria that can host these different resistant mechanisms. First being carbapentamases, and these are specific beta-lactamases that are more versatile than just our standard beta-lactamases, as they have the ability to hydrolyze a whole host of different antibiotics. What you see here is the traditional beta-lactam ring, and the carbapentamase will come in and break this up, which disallows the antibiotic from binding to its desired penicillin-binding protein. So first, we'll dive into some common carbapentamases that are associated with Enterobacteriales. As noted previously on the table listed, KPC, or Klebsiella pneumonia carbapentamase, as a class A plasma-mediated enzyme. One of the more scary class B enzymes are listed here, such as the New Delhi metallo-beta-lactamase, the VIM, and the IMP. These are oftentimes associated more commonly outside of the United States, but anecdotally, in my practice as a fellow at UIC, I have seen a handful of IMP-producing Pseudomonas species, so they're definitely present, and we need to be aware of them. For patients that are generally at higher risk of acquiring one of these infections, as I said, they can be sometimes rare. Immunocompromised patients, so someone post-transplant, or patients that are living acute care long-term health settings or have been in and out of the hospital consistently, patients requiring instrumentation, so ventilators, catheters, etc., patients with extended ICU courses or otherwise taking long courses of antibiotics. Carbapenem-resistant Acinetobacter baumannii or CRAB is one of the most resistant pathogens that we'll talk about that was identified by the CDC. These infections typically occur in patients that are in the intensive care unit, again, either after extensive health care or antibiotic exposure. They can cause a host of infectious syndromes, and they can carry plasmid-mediated resistance. So those ambler class genes that were identified can be located on a plasma and actually be transmitted from bacteria to bacteria, even amplifying the resistance within the infection. Some of these carbapenemases make the carbapenem antibiotics ineffective, and again, that helps spread the resistance. And there are instances of specific CRAB isolates showing resistance to nearly all antibiotics, and we're not seeing few new antibiotics are actually developed to target these specific pathogens. So what makes a CRAB definition, how do we define what is a multi-drug resistant Acinetobacter species? So in this case, when it's resistant to more than 2 of the following classes of antibiotics. So our anti-Pseudomonas cephalosporins or our anti-Pseudomonas carbapenems, in addition to ampicillin sulbactam being on the list for quinolones and aminoglycosides. So once it's resistant to 2 of the following 5 classes, then it's associated as an MDR isolate. When we're looking at the MDR isolates over time, as identified by the CDC, we can see that from, again, 2012 to 2017, there has been a decrease in overall cases. And again, this can be attributed to continued infection control efforts, appropriate antimicrobial use assisted by antimicrobial stewardship, and this can help maintain or even decrease the carbapenem-resistant infections that are occurring. From a microbiologic standpoint, this is an aerobic gram-negative rod, commonly found in the environment such as water or soil, and then again, as associated with hospital-acquired infections. The baumannii species is the major species out of the Acinetobacter species list, and occasionally other species here can be found, but again, most oftentimes it will be that baumannii. Again, as far as mechanism of resistance, the 3 main mechanisms listed here are those enzymes that inactivate antibiotics, so things like class D or class B ambler classes. These enzymes that are inactivating the drugs, again, are the beta-lactamases, and they hydrolyze and confer resistance against other various groups of drugs, namely penicillins and carbapenems. Reduced entry into the site or the target site of bacteria, so this is impacted by porin channels, and the presence of porin channels and other outer membrane proteins can help in the delivery of the drug into the targeted proteins of their antibiotic action, but these porin channels can become smaller and lesser, which can prevent the entry of the drug, causing it to become resistant. And we can also see alteration of the target or cellular functions due to different mutations. These changes in the membranes affect binding and changes in bacterial targets, again, due to point mutations, and this impacts selective pressure exerted by these broad-spectrum antimicrobials. And again, these plasmids can be then transferred between strains among patients and can be the cause of emergence of resistance. So for treatment, unfortunately, as mentioned, there can be cases that arise where we may not be able to optimally treat these patients because we just don't have the tools necessary to do so. Most of the time, the agents that will be active are listed here on the left, such as imipenem, meropenem, ampicillin sulbactam, or tigecycline. For the MDR isolates, dual therapy with a host of different agents can be utilized. In this case, when we have isolates that have MICs that are higher for specific agents, we may be able to overcome that specific resistance by incorporating an extended infusion, or for non-bacteremic pneumonia patients that have pneumonia, we could potentially consider inhaled colistin for them. Moving forward to our carbapenem-resistant Enterobacteriales, carbapenem-resistant Enterobacterialis, or CRE, are commonly found in the organisms listed here. And to be defined as a CRE, it's, again, the family of bacteria listed above that are found in the GI tract, soil, water, and they have to test non-susceptible to one of the following carbapenems, specifically either doripenem, meropenem, or imipenem. And some exclude ertapenem resistance from the definition, and I do so here. Resistance also needs to be to all of the following third-generation cephalosporins listed, and that's when we can classify a specific isolate as a carbapenem-resistant Enterobacterialis. As we see here, CRE cases over time, unfortunately, are not following the same trend as some of the other resistant pathogens that we've reviewed. Strategies that have helped contain patients that are infected with CRE isolates have prevented further spread in the United States, but obviously continued action is needed in identifying these isolates and incorporating infection control as well as appropriate antimicrobial prescribing.
Hey, Fischer, sorry to interrupt again, but your volume is getting pretty low again. If you could speak up or move closer to your microphone.
Yep. I'm so sorry.
Right. Thank you. Sorry.
No worries. We're trying to work through this. My neighbors will just get a nice talk about antimicrobial resistance. So here we have the optimized treatment for CRE as an algorithm that was put together. It identifies risk factors as well as appropriate microbiologic data that can help once we're beyond empiric treatment and moving towards definitive treatment. But as you can see, combination regimens, even upwards of triple therapy, can help us adequately cover someone with an empiric regimen. And based on some of these risk factors listed above can help determine what that empiric regimen will be. Things such as colistin, utilizing a carbapenem or aminoglycoside, tigecycline, fosfomycin, etc. And then once we have those microbiologic data, we could potentially resort to monotherapy, or again, combination therapy may be needed based on the specific susceptibility pattern of the isolate. And listed here, it's the monotherapy options as well as some other combination-based therapies. Moving forward to multi-drug-resistant Pseudomonas aeruginosa, some types of these multi-drug-resistant or MDR Pseudomonas or difficult-to-treat resistant or DTR Pseudomonas, again, can follow in the same path as the crab species and can be nearly resistant to all antibiotics. For an MDR to be defined in that category, it needs to be non-susceptible to at least one antibiotic in the following three classes. And to be a difficult-to-treat resistant, they have to be non-susceptible to all of the following classes. So you can see it is a little bit of a tiered approach, and the difficult-to-treat resistance being the more severely resistant isolate if identified. Again, from the CDC, looking at our cases over time from an infection control standpoint, we can see they are decreasing from 2012 to 2017, which is a good trend to see. And the problem with Pseudomonas and its multi-drug resistance is that it can occur in multiple ways. So we can have our chromosomal-induced beta-lactamases, we can have our efflux pumps, we could have our potential ambulatory class mechanisms and beta-lactamases in that setting, as well as altered permeability to the cell itself through porin alteration. Carbapenem resistance often occurs in the loss of the outer membrane, or OPRD, and that is what infers resistance to carbapenems. This, in combination with other mechanisms, can be a major determinant of resistance to carbapenems. And as mentioned, they can hold a whole host of different resistance mechanisms, and not even excluding ambulatory class B, one of the most resistant ambulatory classes that we can see in our resistant isolates. As far as treatment, again, looking at empiric versus definitive treatment on the top, we have risk factors that will help drive our empiric treatment. Again, similar to what we experienced before, dual combination regimens may be employed to help with our probability of having adequate initial treatment and adequate initial coverage before we get into that definitive treatment on the right-hand side, using our microbiologic data and determining for specific minimum inhibitory concentrations may help us find a monotherapy that will be adequate, something like ceftolozane, tazobactam, meropenem, even something like ceftazidime, or again, resorting to maybe more of our beta-lactam combinations, or when we have a beta-lactam resistant isolate, even going further down the pipeline for things like dual combination therapy with gentamicin or colistin, etc. So now we'll move into some of the drugs that I've been talking about with a little bit more in detail about them in particular. First, just the carbapenems, so imipenem, cilastatin, as well as meropenem, being the two more common carbapenems that we'll use for these more resistant isolates. They are first-line choices for our ESBL organisms, and they're active against a whole host of gram-negative and gram-positive aerobic and anaerobic. Sometimes I think it's easier when we think about carbapenems to talk about bacteria that are not covered or they're holes in their spectrum, which those are listed here. And again, resistance can be rare to these antibiotics, and oftentimes they're not necessary empirically. But when we are concerned about those organisms that we discussed, they can even be resistant to these very broad antibiotics. Here we have ceftazidime avibactam as one of our novel beta-lactam beta-lactamase inhibitor combos with the brand name as Avicaz. It is FDA indicated for complicated intra-abdominal infections when co-administered with metronidazole, as well as complicated urinary tract infections. It's a combination of our third-generation cephalosporin, ceftazidime, as well as our novel beta-lactamase inhibitor. Ceftazidime binds to the penicillin-binding proteins, which helps inhibit the bacterial cell wall synthesis, while avibactam protects that ceftazidime from those beta-lactamases that were being produced. What we see here from coverage from Avicaz, or ceftazidime avibactam, is activity against those KPC-producing carbapenem-resistant Enterobacteriales, as well as our OXA48-producing organisms. And actually, the addition of avibactam can sometimes restore ceftazidime coverage to Pseudomonas isolates that were resistant to ceftazidime alone. And at the bottom is the recommended dosing. Up next, ceftolozane tazobactam, or brand named Zerbaxa, is another beta-lactam beta-lactamase inhibitor combination, which is FDA indicated for complicated intra-abdominal infections, as well as HAP/VAP and complicated UTIs. The ASPECT MP trial was the trial that it was in comparison against meropenem for nosocomial pneumonia. It was found to be inferior. The niche for this particular broad spectrum combination is it's very active against our multi-drug resistant Pseudomonas. So when we were discussing those isolates earlier, this is one of our best agents to help combat and overcome that resistance in particular. But it does have variable activity against just our classic ESBL producing organisms, especially in Klebsiella pneumonia. So that's something to keep in mind if you were concerned about using this agent empirically just for a presumed multi-drug resistant infection. With the dosing there at the bottom, with a bit of a different dose studied in that ASPECT MP trial, which is another key component to take in mind dependent upon the actual infectious syndrome of the patient that you're treating. Next is the meropenem vaborbactam, or Vabomere. This is FDA indicated for complicated UTIs and pyelonephritis, not FDA indicated for the intra-abdominal infections. This was studied via Tango 2, where evaluated against best available therapy for CRE infections. Most of the time, that best available therapy was a combination of a polymyxin, either colistin or polymyxin B, and it was found to be associated with increased clinical cure, decreased mortality, and reduced nephrotoxicity. From our coverage standpoint, vaborbactam inhibits class A beta-lactamases as well as KPC-producing organisms. It does not inhibit our metallo-beta-lactamases or our class D beta-lactamases such as the OXA48, but it is active against carbapenem non-susceptible Pseudomonas aeruginosa. And again, our dosing regimen listed at the bottom. Up next, we have imipenem cilastatin relibactam, or brand name Ricarbrio. This is FDA indicated for UTIs as well as acute pyelo, as well as complicated intra-abdominal infections. It was studied via the Restore ME2 trial, in which it was non-inferior to piperacillin tazobactam in a HAP/VAP setting. It has a wide variety of coverage over our resistant organisms as well, with activity against KPC-producing carbapenemases and class C beta-lactamases, with little to no activity in the class B and class D ambler classes of beta-lactamases. It does have improved activity against CRE strains, but does not have improved activity against our Acinetobacter or Cenotrophomonas species. Here's just a brief overview of the beta-lactam, beta-lactamase combinations that are more of our novel agents in this setting, with just a summary of which agents empirically could you potentially use for a particular ambler class before identifying susceptibility data and potentially as assisting in an empiric choice. As we can see here, ceftazidime, avibactam, covering all of our ambler classes except for class B. Moving into some different classes of antibiotics beyond our beta-lactam, beta-lactamase combinations. Eravacycline is a first synthetic fluorocycline antibiotic, and it's approved for intra-abdominal infections. With dosing listed here, there are no renal dose adjustments for this particular agent, but there is a dose adjustment recommended when there's liver impairment, and it works by reversibly binding to the 30S ribosomal subunit in targeted bacteria. And those bacteria can include organisms such as ESBL, producing Enterobacteriales, can also include Staph aureus, including MRSA, enterococcal species, and Bacteroides, but is not indicated for the treatment of urinary tract infections, with which oftentimes these organisms may be the culprit in those settings. Moving on next, we have cefiderocol. This is a unique cephalosporin that's attached to a catechol side chain, which uses an iron substrate. It acts almost as a Trojan horse to actively enter bacterial cells, in addition to passive entry via other porin channels. These natural cytophores that are attached in this side chain bind to the iron and chelate, and that's what assists it to sort of sneak into the bacteria and exhibit its mechanism of action. Listed here is some ongoing studies that were identified on clinicaltrials.gov with the Aspects MP trial looking at hospital-acquired pneumonia, as well as the Credible CR trial looking at nosocomial pneumonia, bloodstream infections, and sepsis, or complicated urinary tract infections. Overall, it has a broad range of activity, as you can see here, all the species listed, and it can have activity against all of our ambler class producing organisms. In addition, the dosing is IV only, 2 grams every 8 hours over 3 hours, and the pharmacist in me always likes to note that it actually requires renal dose adjustments when their creatinine clearance is at a certain threshold higher than 120 mils per minute, which is a unique indication for renal dosing adjustments, and some potential side effects listed here as well. So to wrap up with, I have 2 separate novel beta-lactamase protecting agents. We have the nacubactam in combination with meropenem. It's the first in its class of a diazobicyclooctane or DBO beta-lactamase inhibitor. This helps inactivate class A, C, and D beta-lactamases in our ambler class classification, and it has restored susceptibility of meropenem to KPC producing isolates. As of right now, there have only been safety trials conducted in healthy volunteers, and the doses that are listed there, and there has not been any sort of red flags in addition of the nacubactam and it causing additional side effects. So be on the lookout for potentially this agent coming soon. And then zidibactam, in this particular beta-lactamase inhibitors in combination with cefepime, so one of our 4th generation cephalosporins, and this has combination activity against our MDR gram-negative bacteria, again including those pesky carbapenemase expressing crab species. Its mechanism is similar to other combinations in this setting, concurrent multiple penicillin binding protein inhibition, leading to enhanced activation of the beta-lactam core, in this case cefepime. And it's found to be highly active, again, against these MDR isolates, and it's inhibited ambler class A, B, and D, and it has activity against Pseudomonas, which has multiple resistance mechanisms possible. So with that, I know that there is a short break after this, so we may have some little bit of time for questions before that occurs.
So I'm not seeing any questions. I think you were very thorough in that presentation. Thank you so much. That was excellent. Like you mentioned, we do have a little bit of a break now. It's our lunch break. So if anyone wants to go and grab lunch, please feel free to do so. But also please note that we are having our poster presentations during this lunch hour. So please head over to the poster presentation tab and view some of the excellent posters that we have available there. And a couple of the presenters are even able to present live. So please go and interact with them. And our next afternoon session will begin at 1:30.